Great. Great. Thank you so much, Eva. And thank you very much for the invitation to speak here today. Today, I'm going to talk a little bit about the work that we've been doing in a sort of comparative, or taking a comparative approach to immunotherapy to treat osteosarcoma in dogs, and then how that could potentially translate into the treatment of human osteosarcoma. So just to I know we have a sort of a mixed audience here today, so there's going to be some sort of high level and some science and some clinical activity going on, but really wanted to just sort of take a step back and just look at osteosarcoma in humans and osteosarcoma in dogs, and just compare the two, because it is one of the tumors that we know is very similar between humans and dogs, and not just similar as I've shown here in this sort of collage of pictures, not just similar in terms of its clinical presentation, which is frequently a sort of large swelling pain over bones in the appendicular skeleton, particularly proximal humerus, distal radius. And the radiographic findings are really quite similar as well. So here in this proximal humerus, we can see this very sort of classic starburst appearance of this tumor. And also, of course, accompanied by significant lysis, and we can see that particularly well in the distal radius of this particular canine patient. And the treatment between human and canines with osteosarcoma is also relatively similar. The concept is to remove the primary tumor, and that, of course, in the past was done in humans with amputation, now more commonly with limb-sparing surgery. In the dogs, we're still mostly amputating these affected limbs. And then, of course, chemotherapy to try to address the micrometastases that we know are present, at least in the dogs, in probably about 85–90% of those cases. And indeed, it is because this tumor is so aggressive and metastatic that we tend to lose the majority of dogs that we see with osteosarcoma to metastatic disease. And you can see the sort of idea here that we can see the picture, a radiographic appearance of these cannonball metastases in a patient that has undergone amputation and chemotherapy and has gone on to develop metastatic disease. So we see this in the majority of canine patients, and the majority of them will develop metastatic disease within 1 year of diagnosis, and that's after undergoing amputation and 4 doses of carboplatin, which is the standard sort of chemotherapy that's given after the amputation. In humans, they'll often have chemotherapy prior to amputation or limb-sparing surgery, and then they'll have follow-up chemotherapy as well. And about 70% of those children are in fact cured. 30% unfortunately will go on to develop metastatic disease, or may have metastatic disease at the time that they are diagnosed. And really, both for humans and dogs, there is no effective treatment for metastatic disease. I do just want to mention as well, when we talk about those 70% of children that are actually cured from this disease, the morbidity that is associated with the chemotherapy, high intensity chemotherapy that they have, is quite significant. And so that shouldn't be underestimated. And we really need sort of better treatments for kids and also for dogs that develop this disease. A couple of differences that you can see here. We see a lot more osteosarcoma in dogs than we do in humans. It tends to affect these giant breed dogs, large breed dogs, and it tends to occur at middle to older age in dogs, which is quite different. Usually in humans, we'll see this in the first or second decade of life. So there are a couple of differences. And I think the important thing here is that because we have so many dogs that develop osteosarcoma, there is a wonderful opportunity for us to leverage dogs that spontaneously develop this disease to find novel ways to treat it, and then to take those over into people. So this just shows the attempts that have been made over the last 30+ years just some of the attempts that have been made to improve the survival in canine patients with osteosarcoma. And you can see that really, unfortunately, we haven't been able to move the needle here in terms of improving the median survival of dogs that are diagnosed with this disease. And most, of course, of these therapies that are being utilized are chemotherapy. So you can see carboplatin and doxorubicin, for example, cisplatin in the earlier days, and on from there. But really, despite this, and some small molecule inhibitors, despite this, we haven't been able to make a difference in the overall survival of these dogs. And unfortunately, the situation is quite similar in children as well. But what we do know from history, as well as clinical evaluation more recently, is that osteosarcoma does seem to be an immune responsive malignancy, an immune responsive disease. And we know that back in the work, back in the day of William Coley, who was an orthopedic surgeon at Memorial Sloan Kettering. And he noticed that patients that developed osteosarcoma that also had concurrent infections, bone sarcomas that also had concurrent infections, were actually, in some cases, able to control their disease and even underwent some regressions. And so he sort of hypothesized that perhaps if you were to treat patients with osteosarcoma that didn't have concurrent bacterial infections with a bacterial sort of concoction, could you in actual fact induce some sort of control of this disease, and could you sort of prevent metastatic disease in these patients? And of course, back in the day then, there weren't really sort of controlled clinical trials, but anecdotally, he was able to demonstrate that through his concoction of strep and Serratia bacteria, he could actually cause some control of the disease and some prevention of metastatic disease. We've actually seen the same thing in the dogs about 100 years later, where surgeons that are basically performing limb sparing techniques in the dogs actually identified those patients that actually developed bacterial infections after limb salvage surgery could actually enjoy much longer survival time. So in this first paper here, they were looking at survival times of patients that had bacterial infections following salvage surgery of about 17, 18 months, compared to 7 months in patients that had the same surgery but did not develop bacterial infections. And that concept was seen again in these other 2 papers as well. Although it wasn't the focus of these papers, they identified a statistically significant increase in survival in canine patients that developed bacterial infections after limb salvage surgery. So the suggestion there was that some sort of general non-specific immune stimulus was actually able to control the development of metastatic disease and delay that development, which resulted in improved survival. And then more recently, people have actually been looking at the tumor itself, the tumor microenvironment, and looking to see the influence of immune cell infiltrate into those tumors on survival. And this is actually work that was published back in 2018, and this is actually human data that was influenced by transcriptomic profiling in canine osteosarcoma, where they actually identified particular immune clusters by RNA-seq, and were able to demonstrate that those patients that had high levels of these particular immune clusters enjoyed a longer survival period and longer time to metastatic disease than those to developing metastatic disease than those that had an absence of these immune clusters. So clearly this sort of tells us that there is some sort of immunological control that could potentially be leveraged to actually improve the outcome of these patients. And indeed, again, back in the day now, this is back in sort of the 80s, work out of the University of Wisconsin started to look at this using muramyl tripeptides, which were basically an extract of mycobacterial cell walls. And they performed amputation in dogs with osteosarcoma. They performed follow-up cisplatin. Back then it was cisplatin, now carboplatin. And after that chemotherapy, they followed up then with muramyl tripeptides as a non-specific immune stimulus. And what they were able to show is that those patients that received the muromyl tripeptides enjoyed an increase in median survival time. I think now, as we know more about immunotherapy and clinical trials in immunotherapy, we sort of recognize we perhaps would present this a little differently, in as much as, yes, there has been some slight improvement in median survival time, but I think what's more important is that you've been able to sort of what we call raise the tail of this survival curve, that a number of these dogs were actually enjoying significantly prolonged survival. And that is really what's clear. There was a subset of these dogs that were responding and having this long-term survival. And so the goal now is to see if we can actually raise this tail further and get more of those dogs responding. And how to do that is of course, what everybody's trying to do. And then based on this canine data, the muromyl tripeptides were taken over into the pediatric world here and shown to have some moderate improvement in overall survival in pediatric patients. And this is actually now approved for the treatment of osteosarcoma in Europe in kids. So that really was looking at sort of a non-specific immune stimulus, much like Coley had done. But perhaps if we were able to target the immune system more specifically to the micrometastases that we're trying to eliminate, we would have more success. And so one of the ways in which we've started to think about this is to actually take advantage of bacteria, certain bacteria and their properties. And so we've been exploring the use of Listeria as a potential immunotherapeutic. And so often we're sort of asked, well, why Listeria? And really it's the sort of relatively unique biology of Listeria that lends itself to a effective vaccine. So when we think about Listeria, just talking about the biology of this particular bacteria, as its name suggests, monocytogenes, it tends to have a propensity to go to mononuclear cells, which of course are antigen presenting cells. And so the Listeria will be taken up into the antigen presenting cell. It will be degraded within the phage lysosome, and then it will be presented on the surface of that antigen presenting cell in the context of MHC class 2 to CD4 T cells. So those are helper T cells. However, and that's of course what most bacteria will happen to most bacteria. But Listeria is unique in the fact that it actually has this property where it can actually escape from the phage lysosome. So as that phagocytic vacuole joins with the lysosome, the pH will drop, and the Listeria will start to secrete LLO, which is Listeria lysine O, and that's a pore-forming molecule. And so the Listeria can actually escape now into the cytosol, and there it will be processed through the proteasome to be presented on the surface of MHC class 1 molecules to stimulate CD8 T cells, so killer T cells. So what we can actually do is we can take that LLO molecule and fuse antigens of interest to LLO and use the Listeria essentially as a sort of Trojan horse to deliver those tumor-associated antigens into antigen-presenting cells and get them presented both to helper T cells as well as cytotoxic T cells. And of course, we know that Listeria is a very potent stimulator of innate immunity as well as adaptive immunity. So we have this very sort of profound and robust innate and adaptive immune stimulus, and we can use that, the Listeria and the properties with LLO to redirect or direct that immune response against a particular antigen of interest. So what antigens are we going to go after? And this is, of course, always the issue, particularly with sarcomas. And so there's been a number of these genetic factors that have been associated and comparable between human and canine osteosarcoma, and they're listed here. But one of the particular antigens that we had an interest in was HER2/neu, an epidermal growth factor receptor. And we and others have demonstrated in canine osteosarcoma, and you can see by immunohistochemistry here and then by Western blot on the right-hand side, that we do see HER2 being expressed in osteosarcoma. And that is the same actually in pediatric osteosarcoma as well. There's some strange sort of nuances of HER2 expression in osteosarcoma. We don't tend to see membranous expression like we would see with HER2 in carcinomas. It tends to be intracellular, which is a little unusual. And so it's not a particularly good target for monoclonal antibody therapy like trastuzumab, and that has actually failed in pediatric osteosarcoma clinical trials. But of course, it can still be an important target for T cells. And so that's, of course, what we're trying to induce when we use a listeria immunotherapy. So, of course, probably not a good idea to go giving live unattenuated listeria to patients. So we have to sort of attenuate this bacteria to decrease its virulence and make it acceptable. And so the way that this has been done is through genetic modification. And there are several mutations that we've made in listeria to allow it to be utilized effectively and safely. So there's an irreversible ACT-A deletion. So this prevents the bacteria from utilizing actin to move around the cell and to get from cell to cell. So once it goes into the cell, it can't get out of the cell. And then there's also mutations in the DAL and DAT genes, which are involved in D-alanine synthesis, which is required for the viability of the bacteria. So we basically have this DAL-DAT delta ACT-A strain, or what we call LNDDA strain, and it is highly, highly attenuated. And you can see that on the right-hand side here, when we actually give this attenuated bacteria to mice that have had interferon gamma gene knocked out, so they are quite immunosuppressed, they can clear very nicely the bacteria from the liver in the black and the spleen in the white. Within 3 days, the listeria has gone. So highly attenuated, very easy to clear it, even if you are immunocompromised. So with this strain of bacteria, we can then transfect it with our plasmid, which obviously has the antigenic payload associated with it. And in this case, we're using HER2. And we actually have a human HER2 here. It's the extracellular 1 and 2 and an intracellular domain of HER2 that contain the immunodominant epitopes of HER2 for humans, at least. And that is then fused to a truncated listeria lysine O. And that plasmid is maintained within this attenuated listeria strain through this auxotrophic complementation of DAL here. So there's no antibiotic selection, which is, of course, important again for safety. And so there's been a huge amount of work that's been done with this vaccine, utilizing various mouse models, and I've just sort of shown 2 here. And this is obviously from quite some time ago now, but taking a HER2 expressing tumor in mice, implanting that, waiting for these tumors to grow so that we have a pre-existing tumor, and then vaccinating these mice with listeria that is expressing HER2 new, you can see that we can actually control the growth of these tumors, and in some case actually eliminate those tumors when the listeria contains extracellular domains of HER2. But when the listeria contains an irrelevant antigen, in this case E7, it cannot control the growth. So this is more than just a sort of Coley's toxins effect. You actually need to have the target antigen in your listeria to induce this control. Also, and importantly, as we're thinking about moving this into an osteosarcoma setting, this group have been able to demonstrate that actually if you pre-vaccinate these particular mice prior to administration of a HER2 expressing breast carcinoma cell line that is highly metastatic, you can actually prevent metastatic disease, as shown here in this bioluminescence. And again, this is a control listeria given, so obviously we'll have the Coley's toxin-like effect. That does not control the metastasis from this HER2 positive line, whereas the listeria that does express the chimeric HER2 can control the disease. And so that led to this concept. Well, if we have this ability to stimulate HER2 specific immunity and control HER2 positive tumors, could we actually utilize that in the setting of minimal residual disease to prevent metastases in dogs with osteosarcoma? And so this was the pilot design here, was to diagnose patients with osteosarcoma, to let them undergo standard of care treatment, which is amputation, and then follow up with 4 doses of carboplatin as shown here. They would then undergo a screening visit, and only if they were free of metastatic disease at that time point would they then be shuttled into the treatment arm here. So they would receive 3 doses of this listeria vaccine, which is called Advaxis 31164. And that would be given 3 weeks apart. And then 3 weeks after that last vaccine, they would be screened to see if they had metastatic disease and be restaged. And then they would be restaged every 2 months to determine when they're actually developing metastatic disease. And so we were really very interested in understanding, is this vaccine safe to give to these patients, and what would be the maximum tolerated dose as well. So this was a 3+3 clinical trial dose escalation. Our secondary outcomes were disease-free interval and overall survival. And important points to point out here is all these dogs were screened. Their primary tumors were screened for the expression of HER2/neu by immunohistochemistry. And only if they had greater than 10% of their tumor cells expressing HER2 were they eligible for the study. Also, the other point to mention is that these dogs were able to receive booster vaccines if their owners wished for that to happen. And the majority of these dogs did come back for booster vaccines. And so that's important just to point out, because it's somewhat different to the national study that I'm going to talk about after this one. So this is just the dogs that were enrolled. This is work that has been published, and these are our dose escalations, as you can see. Most of the dogs, large breed dogs, as we would expect. Tumor locations, very classic, proximal humerus, distal radius, and so forth, and most of the subtypes osteoblastic as well. And you can see this HER2 score here, which was based on immunohistochemistry. So what are the side effects? Well, fortunately, and we were pleased to see, transient low-grade side effects occurred in these patients. So after an intravenous infusion of these increasing doses of listeria, so going from 2 × 10⁸ colony-forming units total dose up to 3.3 × 10⁹, you can see what happens in pretty much all of these dogs by about 4 hours is they have an increase in their body temperature. And that potentially seems to increase as the dose increases. And so that was the most common side effect, was pyrexia. As we would expect, as that listeria goes in and starts to activate the immune system, we're starting to get the release of pyrexic cytokines like IL-6, TNF-alpha, IL-1, which will increase the temperature in those patients. Certainly, we saw evidence of nausea in a number of these patients as well, and some episodes of vomiting around about that 2 to 4 hour mark, when that immune response was really starting to get revved up. But as you can see, after that sort of peak pyrexic point at 4 hours, we start then to see the fever slowly coming down. And these patients were really sort of discharged after 6 or 8 hours of being in the hospital after receiving listeria. They were able to go home, and usually sort of ate dinner before they went home and then left. And the owners reported really no adverse effects at home, maybe a day of lethargy the next day. So safe, transient, low-grade adverse effects. So this is a busy slide. I'm just going to sort of distill it down. So one of the questions we wanted to know was whether that vaccine could stimulate HER2-specific immunity in these dogs. And so one of the first things we looked at was ELISpot analysis against HER2s, and these were pooled peptides. And so at baseline, you can see that all of these dogs, bar one, had no evidence of interferon gamma immunity against HER2 peptides. This dog 16, actually died from a nephroblastoma that was not detected at the time he was enrolled. So I don't know if that's one of the reasons why perhaps there's some HER2 positivity. But as you can see, what we see in these patients after, and this was taken 3 weeks after the 3rd vaccine, we start to see evidence of HER2-specific T-cell responses in some of these patients. And of course, the number of pluses here indicates that the fold increase in ELISpots that you can see. these actually responses could be somewhat delayed. So quite interestingly, here in dog number 2, the gray bars here indicate relapse. And so this dog was actually, we found that there was metastatic disease early on in this particular dog, and that dog developed HER2-specific immunological responses after he developed metastatic disease. Unfortunately, he didn't go on to do particularly well, but this sort of suggests that there was some sort of additional potential stimulus for HER2 to actually, these HER2-specific responses to come up. And then you can sort of get some idea of how these responses sort of waxed and waned, and how you sort of start to see the days that these patients were actually surviving was really quite remarkable when we start to think about a general overall survival being around about, 360 days is standard, so about a year. You can see these patients were really starting to demonstrate quite prolonged overall survival. And this is the Kaplan-Meier survival curves here. So we can see with our vaccinated dogs, we did see a statistically significant increase in disease-free interval and in overall survival. And that's just documented down here in our vaccinated group. Certainly longer than a historical control group that was selected based on HER2 positivity in the tumor and lack of metastatic disease at the time they would have been vaccinated. So a useful control group, but nevertheless a historical control group. And of course, this is going to be better than published retrospective studies, because we selected those dogs that did not have metastatic disease after carboplatin. And that eliminates about a third of them, because about a third of dogs will develop metastatic disease during chemotherapy. So that then led us to a multi-institutional study to ask, on a much larger scale, this was of course a small number of dogs, 18 dogs, whether this vaccination approach could in fact really prevent metastatic disease in these dogs. And so we were also interested in looking at more sort of immunological correlates of which dogs might respond to this vaccine and which dogs would not. And so this was just the trial setup, very similar to what I've just shown you: amputation, 4 doses of carboplatin. Those dogs that were free of metastatic disease would then receive this listeria vaccine, 1 vaccine every 3 weeks for a total of 3 doses. And then they would be restaged 2 weeks after that last vaccine. If they were free of metastatic disease at that time point, they were determined to be evaluable. And those are the dogs that we then went on to look at immunologically. A couple of important differences from the pilot study. In this particular study, dogs were not screened for HER2 positivity, so that was not an eligibility criteria. The other important point is only 3 doses of the vaccine were given. They did not have booster vaccines, and that was a decision that was made based on cost, unfortunately. We also had this correlative immunological biomarkers being explored as well. And there was a standard of care group that we compared this to. It was not a randomized clinical trial. This control group was collected prior in a study that was evaluating the addition of rapamycin to standard of care arm. Nevertheless, the dogs underwent, in that standard of care arm, underwent amputation, carboplatin, and they were evaluated at exactly the same time as these listeria dogs, but obviously they didn't receive the vaccine. So, and this just shows the sites that were involved in recruiting these patients to the clinical trial. Now, we had a total of 118 dogs that were included. That was the intent to treat group, and 75 of those dogs ended up being in the evaluable group. So just to demonstrate here the patient characteristics, and this is unpublished data, it just demonstrates that the groups with listeria versus the standard of care were really very similar in terms of their signalment, in terms of age and weight, sex, alkaline phosphatase status, which is shown to be prognostic in canine osteosarcoma, and also their tumor locations as well. So very sort of similar groups. Unfortunately, we did not see in that multi-institutional study a improvement in disease-free interval or overall survival with the listeria, which obviously was quite disappointing. And, you know, reasons for that we can discuss. Certainly the potential of not enrolling HER2 positive dogs, the potential of not giving repeat vaccines. But I do think that what we were able to discover was very important with respect to these immunological assays that we performed in these dogs. And that's really what I want to focus on here, which is taking those evaluable dogs. So those are the dogs that made it out. They had 3 doses of listeria, and they then showed up at week 23 for evaluation. So those are the ones that we're calling the evaluable dogs. And here's the Kaplan-Meier curve for disease-free interval for those evaluable dogs. And so what we did then is we said, right, how could we split these dogs up? What determines whether you're going to be a dog that has a very short disease-free interval or a dog that has a very long disease-free interval? Is there a difference in these dogs, either in terms of their presentation or in terms of their ability to respond to the vaccine? And so looking at these dogs, we took those 25 dogs that were at the top end of the scale, so those with the longest disease-free interval, greater than 490 days, and the dogs that had the shortest at the bottom end, and those 25. And those are the two groups that we're looking at. And you can see that really they're very evenly matched with respect to their age, again, their weight, their sex, their alkaline phosphatase status, and the tumor location. So we could not distinguish based on these characteristics who was going to do well and who was going to do poorly. What we did find, what was interesting, is just looking at the first vaccination here. When we looked at those dogs that we're going to call sort of the elite survivors in green here, we could see that there was a statistically significant increase simply in their body temperature at 4 hours after the first vaccination. So they clearly were able to develop this pyrexic response to the intravenous listeria vaccine. And yet when we looked at the dogs that did not survive long, so had a much shorter disease-free interval, we did not see that increase in cytokines. So clearly right off the bat, there is a difference in those dogs that are going to go on and do well and in those dogs that go on to do poorly in their immunological capability to respond to the vaccine. So could we pick this up perhaps by just looking sort of at hematology? And we know from that pilot study that after vaccination, these dogs develop an increase in white blood cells, or leukocytosis. And we didn't see any difference when we looked 24 hours after the first vaccine between those dogs that we will consider elite survivors versus poor survivors. So they were, in both groups, we could see an increase in response of white blood cells. So that's not going to enable us to sort of separate out who goes on to do well and who doesn't. But what we were able to identify was a difference in the cytokines that these dogs were able to produce after that first vaccination. So if we just take here, this is cytokine beta ray. Again, we're looking prior to the first vaccine and then 4 hours after the first vaccine. And so at the bottom here, we have the elite response, the elite survivors, and I'll tell you why we're sort of being careful about those terms, or poor survivors at the bottom here, pre and post that first vaccination at 4 hours. And so in those dogs that are able to survive longer, so the elite survivors, again, we see a statistically significant increase in the ability to produce a wide range of cytokines. I'm just showing you here GM-CSF, interferon gamma, IL-2, compared to those dogs who had much shorter disease-free intervals, where they really didn't seem to be able to increase these particular cytokines. And so there is clearly at that first level, so this is 3 weeks after the last carboplatin, these dogs were unable to respond appropriately to listeria vaccination. Some of the cytokines, they were able to show an increase. So if we look, for example, at IL-6 and TNF-alpha, so some of those pyrexic cytokines, we were able to show that the dogs that had poor survival, so shorter disease-free intervals, we actually were able to show that they could increase production of IL-6 and TNF-alpha, but there were quantitative differences in their ability to produce them. So they weren't able to produce as much as we saw with those dogs that had longer disease-free intervals. So again, an inability really, a qualitative as well as quantitative differences in the ability of these dogs to respond to Listeria. And then when we looked after 3 vaccines at the time of this sort of evaluation, after their 3 vaccines, and compared gene expression profiles of peripheral blood mononuclear cells immediately prior to vaccination, the first vaccination, and then 3 weeks after the last vaccination, we were able to show again clear differences in the ability of those dogs to respond to the vaccine, whether they were elite survivors or poor survivors. And so you can see here in these volcano plots, we were actually able to demonstrate in those elite survivors, we start to see upregulation of genes that are involved in cytotoxic responses. So T cell responses, natural killer cells, clearly being upregulated. So 41 differentially expressed genes in those elite survivors compared to a really sort of very poor response in those dogs that developed disease-free, that had shorter disease-free intervals and developed metastatic disease sooner. So not just sort of innate functional defects, but defects in cytotoxic responses as well, that might be intrinsic or might be secondary to poor innate responses and difficulties really sort of kicking off that adaptive response. So, you know, what could we sort of think about this as we sort of step back? We know sort of in these patients after their chemotherapy, in these canine patients after their chemotherapy, there seems to be sort of perhaps these sort of adverse effects on innate immune function. Now, I'm not saying that that's associated with chemotherapy. That certainly could be intrinsic. It could be associated with more advanced disease process that we're not picking up by relatively insensitive radiographs. But we have also a group that have robust innate immune function, and we know that those are the dogs that go on to do well. And so, you know, the question would be, you know, should we be starting to find some way of evaluating immune function in these patients straight after chemotherapy to determine whether they could actually respond to an immune stimulus or not. And if they can respond to an immune stimulus, then maybe these are the dogs that need to get shuttled into immunological or immunotherapeutic groups. And if they can't respond to an immune stimulus, maybe they need some sort of bridging immune support to get them through until perhaps their immune function can recover. And I'm not showing you that data, but there is a suggestions that these dogs, somewhat surprisingly, can actually recover their immune function the further they go out from that last chemotherapy, even though they go on to have shorter disease-free intervals. And then, of course, the question is, if we repeated vaccination, so if we kept going with these vaccines, could we actually lead to an effective cytotoxic response in both groups that would then result in prolonged disease-free intervals and overall survival? So I want to switch gears a little bit now and just talk about sort of a way that we started to think more about this idea of vaccination and the timing of vaccination. And so we were interested in sort of thinking, well, should we actually be thinking about vaccinating these patients earlier? So should we be thinking about vaccinating these patients prior to perhaps chemotherapy or even prior to amputation and start to induce an immune response before these patients underwent amputation and chemotherapy and get them early? Remember that 1/3 of our patients develop metastatic disease during chemotherapy. And that, of course, then is going to be very difficult to deal with, you know, if we're treating them later on. So perhaps we could get some sort of immunological stimulus on board prior. And that's sort of a difficult sell, because in veterinary medicine, we're very keen to sort of immediately remove the leg. We're worried about metastatic disease. So the idea is to take the leg immediately and follow up with chemotherapy. And so it was a difficult sell to try and convince people to sort of delay this vaccination. So then we thought, well, maybe we could do this in that subset of dogs where owners decide not to amputate, either because of concurrent orthopedic problems or cost or just perceived quality of life issues. And so this then led us to think about, well, what could we do this up front? And could we actually demonstrate that this is safe? And could it possibly even be effective in dogs that don't undergo amputation? Of course, the standard of care for those dogs is palliative radiation to reduce pain. And so we also know, of course, that radiation has properties of inducing immunogenic cell death. So, and there are a number of ways in which it does this. So one of the possibilities is we could combine palliative radiation with vaccination and determine whether these dogs could actually do better with that combination type of therapy. The idea being that the irradiation would release these tumor antigens. Those would be picked up by these antigen presenting cells, stimulate T cell immunity that would try, of course, and attack the appendicular, the primary tumor that is still there, but also would have this abscopal effect, being able to sort of go off and treat or eliminate metastatic disease elsewhere. And I haven't had time to talk to you more about the effect of listeria on the tumor microenvironment, but there are studies that demonstrate it does have a permissive effect on the microenvironment by reducing regulatory T cells and myeloid-derived suppressor cells. So this sort of hypothesis made sense to us. And could we actually delay primary disease progression and prevent metastatic disease? So we did a small clinical trial, and this was quite some time ago now, where we took dogs whose owners had opted not to amputate them. We screened them up front. They had to have no evidence of metastatic disease. They had to have histopathologically confirmed diagnosis of osteosarcoma, and they had to be systemically healthy in every other respect. Again, we did not select for HER2 in this study because it was difficult to get people to biopsy the tumors with a potential risk of fracture if they weren't going to receive a treatment that could potentially help them. So we took all comers, we took 15 dogs, they underwent 2 rounds of radiation. So this is just on consecutive days, low dose, 8 gray, directed to the primary tumor on 2 consecutive days, and then 2 to 3 days after they received the first listeria vaccine. And we sort of followed William Coley, and basically just did vaccinations every 3 weeks, as you can see here, out until 8 vaccines. And the reason for that is that would take us past the median sort of survival time that we would see with palliative radiation alone. And then these dogs were offered booster vaccines every 2 months if the owners wished that. And of course, if the dogs were still doing well. And again, we were interested in safety, time to progression, and immune response. So these are the dogs that were recruited to that study. And you can see again, these are all large breed dogs, often proximal humerus dogs. They tend to have a worse or poor survival, a shorter survival. And we had some distal radiuses in there as well. And you can get some idea now of the number of vaccines that these dogs were receiving. And that, of course, gives you an idea how long some of these dogs were actually surviving. And so there certainly were some concurrent treatments, non-steroidal anti-inflammatories, and analgesics like tramadol and gabapentin. And then you can see the time to progression here. Some of these dogs went on to develop pathogenic fractures, and then a couple of these dogs had rescue amputations if the tumor had progressed, and owners decided that they then wanted to amputate. But you can see here that some of these dogs, quite remarkably, survived really quite remarkable lengths of time in response to this type of approach. So just to show you some of these dogs, so this is a dog who came along with a proximal humerus osteosarcoma confirmed on histopathology. This was in January back in 2014, so a decade ago now. Received radiation, received listeria vaccine, and you can sort of see, we get some progression, it seems, here of the tumor. We've got some soft tissue swelling as well, but the dog clinically still doing well. These are the lameness scores at the bottom here. And then the dog came back then in November of that year, and it seemed as though this tumor had sort of stabilized, which is something that we certainly don't usually see. And she received another vaccine at this time point. Then she came back again in January, so now a year later, and again this tumor seems to have sort of stabilized, and still with a relatively mild lameness score. She then came back a year after that, and this is when we started to see some disease progression. But you can see over 2 years, or a year and a half, this patient did not develop metastatic disease, and her overall survival was 894 days. And just to sort of show you I hope this isn't, there is going to be here. This is basically just to show you she's coming in here with her osteosarcoma, proximal humerus. This is her almost, or sort of 9 months later, still relatively sound, which is encouraging. And then here she is in September now of 2015. And this is the owner videoed her for us. She's in blue. There's another one coming in here in red, but the patient with osteosarcoma is in blue. And again, I think sort of surprising that this dog has been diagnosed with osteosarcoma a year and more earlier. She wasn't the only one. Here we have a distal femur patient. Again, this is July of 2014. And as you can see, as this dog comes back through his vaccines, we really just see this tumor just at least both clinically and radiographically seeming to arrest. And again, over the course of several years, no evidence of metastatic disease in this patient. I'm just showing you one chest view, obviously, here. And then we start to see this tumor starting to break through here and progress. And this patient survived for over 1,000 days. And again, just to demonstrate the quality of life issues, this was Luke when he came in July, distal femur tumor. This is him again now, almost 2 years later. Again, just with those 2 doses of radiation and listeria vaccination. And I think you could sort of see that his quality of life there is quite good. I think he actually ended up having cruciate rupture as well, but doing well there. And then we actually had a dog with a distal tibia, again, 2 doses of radiation, vaccination. And you can actually see that it almost seems like the bone is trying to sort of grow back over the lesion, which is quite remarkable. And then almost a year later, this tumor sort of started to progress again. The dog became clinically lame, and the owners opted to actually amputate the dog at that time because he was doing well. He had no evidence of metastatic disease. He had 4 doses of carboplatin to follow up. And you can see here his chest radiographs 3 years after his original diagnosis. This is actually, he was lost to follow up after 13, after sort of 1,316 days. So we lost him to follow up. But again, sort of an evidence here, quite remarkable effect. And then finally, I know we're running out of time. So finally, just to point out another dog that came to us, which was really quite interesting on the original trial. So she was diagnosed with a distal tibial osteosarcoma back in 2012. She underwent amputation. She had 4 doses of carboplatin, and then she had the listeria vaccine in that original trial, underwent booster vaccines. And we followed her out. And she was one, of course, of our long-term survivors. And she kept coming back for repeat radiographs and clinical evaluations. And she came back in 2016, 4 years after her original diagnosis of tibial osteosarcoma. And she was asymptomatic, but on her radiographs, we picked up that she had another sort of presumptive osteosarcoma lesion in that proximal humerus. So she, of course, we didn't want to amputate her. She'd already lost 1 leg. And so we put her into this clinical trial where she had 2 doses of radiation to this lesion. And then we followed her up with listeria again. And then, so this is her now. I don't know why she's in slow motion. It's sort of like the Baywatch video, but I think you can see here that she's utilizing that left forelimb very nicely. And again, sort of good quality of life for her. And she eventually went on to be diagnosed with progressive metastatic disease and was euthanized in 2018, 6 years after her original diagnosis. So sort of, there's a lot to sort of summarize here, and so I'm tempted to do my best in doing that. So I think we can say that the administration of this vaccine, high doses, 3.3 times 10 to the 9 of a live attenuated listeria vaccine, is extremely well tolerated, transient low-grade adverse effects that seem to be associated with innate immune stimulus that it produces. There are no ways to predict the outcome of the response to the listeria, or indeed just the outcome of the patient without any form of immunotherapy. There's no clinical signs that can predict how these patients are going to do, no hematological, no biochemical factors. But what we have been able to identify is that you can sort of distinguish who is going to go on and have long-term disease-free intervals versus who has a much shorter disease-free interval, based on essentially an in vivo immune function test, which is giving listeria. And those patients that respond to that, and you can see an increase in their immune activity, are those patients that are going to enjoy a prolonged disease-free interval compared to those patients that are unable to respond to that listeria vaccine. Now, that's not to say that the listeria is causing the prolongation of disease-free interval, but it is telling us which dogs will go on to do well. We've also been able to demonstrate those defects by gene expression profiling in cytotoxic responses after vaccination, and that they obviously correlate then with disease-free interval. So all pointing to the fact that immunological fitness can actually determine outcome of these patients. And if you have a fit immune system, sort of air quotes, that tends to suggest that you could actually go on and do very well. And so one of the questions would be, what sort of immunological assay could we use and would be relevant to indicate which dogs are going to do well, which dogs have a functional immune system and which dogs do not? And then could we use that to stratify patients to certain treatment groups? As I sort of alluded to, some of these patients, or these patients that have defects in immunity immediately after the chemotherapy, and I haven't shown that data, can actually start to improve their immune function as you go through rounds of vaccination. And so this tends to suggest to us that perhaps what would be valuable is some sort of bridging strategy to support these dogs during that period of time when their immune function is suboptimal, and then continue to vaccinate them or give them some form of immune stimulus to actually start to enable them to generate immune responses that could actually then lead to elimination of micrometastases. I think that one of the sort of issues is target antigen expression. Perhaps we should be selecting these patients based on HER2 expression. I think we probably should continue vaccinating these patients. Just giving 3 vaccines may not be sufficient. And as we started to see in that non-amputation study, these repeat vaccinations may actually be, or repeat immune stimulations may actually be very valuable. And I think we have to start thinking about combination approaches. So as you can see, combination radiation and immunotherapies, or these immunotherapies combined with additional agents that can actually target the immunosuppressive tumor microenvironment, either for the treatment of primary disease or metastatic disease. And I think obviously quite exciting opportunities for us now to start exploring further with respect to radiation therapy and immunotherapies. And so, lots of acknowledgements to give here. People in my lab who've done a lot of the work in evaluating the immune responses in these patients. Certainly our collaborators at NIH in the comparative oncology program, Amy LeBlanc in particular. And then, of course, our sort of trusty mentor, Yvonne Patterson, who really is the inventor of the listeria vaccine, and then all of the COTC clinical trial teams that put together that national study. And so with that, I'm happy to answer any questions that you may have.
Thank you for that. It was really great presentation. I've got, I can't see any questions, but I'm going to give people a chance to type, and I've got a couple of questions just to kick us off.
Sure.
So one of the things noted on your slides was that while you were sort of in between the trials, that the treatment also received an orphan drug status.
Yeah.
So just wonder if you sort of very briefly, obviously slightly outside of your area, but if you would just briefly mention what happened in terms of the drug for the human component.
Sure, yes. So there actually is a pediatric clinical trial ongoing now with the vaccine. And so the canine studies were important in providing safety data for that, particularly cardiotoxicity. So that trial is currently enrolling in the US. I think the average, they're trying to enroll about 45 patients, and I think they're around about 38 or 39 currently. Children that have been treated with this listeria vaccine. It's exactly the same vaccine. I don't know the results of that yet, but these are patients that pediatric patients that have relapsed refractory metastatic osteosarcoma. So they undergo surgery, which is standard of care, to remove the metastases, which are frequently pulmonary metastases. And they have to be free of metastatic disease after that surgery to receive the vaccine. And sort of similar to the non-amputation study that I showed there, and similar to the first pilot study, they are continuing to vaccinate these patients. And I think that's actually quite important, that you need to give a continual stimulus. You can't just give 3 and hope that that's going to do the job. So these patients are being vaccinated, I think, every month, every 3 to 4 weeks, for a total of 48 weeks. And that clinical trial and the details of that clinical trial are available on NIH clinicaltrials.gov.
Thank you. That's really interesting. What was quite fascinating as you were sort of going through the slides and all the different things that you were learning as you went through, when you assume you will be planning other future trials, you've obviously learned quite a lot in terms of perhaps the inclusion criteria as well. What would be the sort of, looking back, what would be the things that you would change that you might think of doing forward in terms of adjusting the inclusion criteria to make sure that the patients that you include are really targeted?
Yes. Yeah, so that's a great question. I think that we know in mouse models that the antigen is important, right? So just there's the Coley's toxins effect is not sufficient. And so it is important that that antigen is present. So I think we would be interested in sort of stratifying the patients based on their HER2 status. Now, the problem with that, and that's one of the reasons why the HER2 status was not actually determined in the national trial, is the ability to detect HER2. So there's immunohistochemistry that we utilize, and there's a cross-reactive antibody that recognizes canine as well as human HER2. But the staining of the osteosarcoma samples is not pretty. And there's a lot of discussion as to whether that HER2 is actually real or not. And that's discussion in the canine as well as the human world. Is HER2, is it there? Does it predict outcome? Because there's suggestions that if you have high HER2 positivity, your outcome is poor. I think people believe it's there. I probably shouldn't have said that. I think people believe that these tumors do express HER2. The fact that it's cytoplasmic, it's intracellular, and it's not expressed so much on the surface of the cells has always been a sort of strange finding that people haven't really been able to understand why that is. But that's one of the reasons why we didn't screen for HER2. The other reason we didn't screen for HER2 in that trial is that the primary tumor has gone, and what we're actually trying to now target are the micrometastases, and we don't know whether they're HER2 positive or not. The suggestion is from studies that have been done in women with breast cancer, that they could have HER2 negative breast cancer, but they actually develop HER2 positive metastases. So if you screen and you find a HER2 negative tumor, that patient, and they've shown that in women, that patient could actually respond to HER2 targeted therapies, and yet you would have sort of screened them out because their primary tumor was negative. So there's sort of difficulties in deciding whether HER2 is measuring HER2 and assessing whether they're HER2 positive is important or not. But it was one clear difference between those that study, that trial that we done in pilot study, where we saw evidence of improved survival versus that national trial. So still, nevertheless, it would be nice to see evidence of HER2 in that primary tumor. Maybe immunohistochemistry is the wrong way to look at it. Maybe we should be looking at it in other ways, like Western blot, for example. Maybe we should look by qPCR just to show that the transcript is there. I would also like to treat these dogs prior to amputation as well. And so, one of the studies I would like to do is actually just as I showed in that non-amputation study, where some of those results were quite remarkable, to treat those dogs with palliative radiation to induce the immunogenic cell death, vaccinate those patients a couple of times, and then amputate them, and follow up, maybe yes, maybe no, with carboplatin, and see how that affects outcome. Because I do think that we need to get this potent immune stimulus on board early. As I've already mentioned, 25 to 33% of dogs will develop metastatic disease during carboplatin. If you're vaccinating them after carboplatin, it's too late. It's going to be very difficult to reverse gross metastatic disease. So I think we need to think more upfront. And I think we also need to think a little bit about what carboplatin is doing to the immune system as well. And so one of the hypotheses might be that carboplatin has sort of a detrimental effect on a subset of patients. And indeed, that might be what's causing them to have sort of a suppressed immune response to an immune stimulus. And the further you get out from carboplatin, the more your immune system seems to be able to respond. And so that's another thing to think about. We don't really think about carboplatin as being a drug that causes a lot of immune suppression, but it's something that we're starting to think a little bit about now. So vaccination early, ideally evidence of HER2, and then keep vaccinating afterwards. And that's how I would design that study.
It would be certainly an interesting multi-center randomized control trial.
Yes.
I think it would require quite a substantial amount of funding, but it would certainly be interesting. Just in the interest of time, I'm just going to ask just a last question. In terms of usefulness of sort of your canine patients compared to any other sort of existing animal models, what would you say is the sort of advantage of what you're doing compared to any other animal models that are out there, which obviously not using naturally occurring disease?
Yeah, I mean, I think that this is really sort of, the advent of immunotherapy has really highlighted the need for spontaneous models. And so I really think that's why the dog is becoming, people are paying much more attention to the dog as an important model, or what I like to call parallel patient population. So when we know tumors, we know that they develop obviously spontaneously, they coerce the immune system. There's a very potent, very powerful immunosuppressive tumor microenvironment that develops in those tumors. And it is a significant barrier to effective immunotherapy. So if you are making a model, you're going to have to just not only model the tumor heterogeneity, the immunosuppressive tumor microenvironment, all of these things have to be modeled. And of course, you have to do it in an immune competent animal. which many of the current models are not. Certainly some of the mouse models are becoming extremely advanced. There's no doubt about it. And the dogs do not replace the mice, of course not. But I think they are going to serve as this very important preclinical translational model that will provide us with the sort of data that I'm starting to show here that could sort of say to us, well, in that pediatric trial that's now ongoing, you should be looking perhaps at cytokines. I know that they're doing these things, but you should be looking at cytokines. You should be looking to see if those patients develop a fever. And we can sort of direct the human clinical trials now to say, hey, it probably would be a good idea to include these types of analyses in this trial, because we've there's a suggestion here that if you are immune competent, you can respond to an immune stimulus. And again, maybe this isn't the listeria vaccine that is responsible for those dogs having prolonged disease-free intervals, but it is an indication that your immune system, if it is fit and active, can control disease. And if you actually stimulate that immune system appropriately, then you may actually get even better responses. So, looking at cytokines, looking at gene expression profiling in these pediatric patients, looking in their peripheral blood, can we actually see evidence of cytotoxic responses, and would that potentially then be predictive of their outcome? So I think it's very important in being able to inform human clinical trials.
Thank you, that's really useful. I think we had somebody wanted to.
Yes, just me, a very quick question, Nicola. And they say there's no such thing as a stupid question, but there may just be. So I apologise in advance.
I don't think so.
That was absolutely fascinating, truly fascinating. One of the things, well, there's a two-parter, and you kind of just answered a little bit there, sort of with the holistic side of things, about a few things. But I was just wondering, obviously the onset of age, I noted it was sort of 7 to 9 years in dogs, whereas it's quite young in adolescents, 10 to 14 years it could start. Is that because it's diagnosed so much sooner? And is there any tests that are being done on pre-diagnosis, if you like, and looking at the history of that animal or human and the actual environment they're living in, and if we can diagnose it so much sooner to give the dogs a far better chance?
Yeah, so that's a great question. So no, I don't. I mean, I guess the answer to the question is we really don't know, but I think it's unlikely that these dogs, develop osteo when they're like 2 years old and it's quiescent until they're 7, 8, 9. Right. I don't think that happens. And we do actually see some osteosarcoma cases in dogs that are sort of 18 to 24 months of age. So there is a sort of a subsection, but it's much, much smaller, that will develop osteosarcoma when they're really, really young. In terms of sort of being able to predict it, not yet. People are now starting to look at sort of circulating tumor DNA and so forth, and looking to see if they can find evidence of circulating tumor cells and so on. But this is sort of still in its fairly early stage. And of course, who do you screen? And when do you screen them? You're going to be taking blood samples from dogs, large giant breed dogs all the time. We do know that a number of these dogs, though, are dogs that are highly predisposed to things like cruciate rupture and so on. So a lot of these dogs are misdiagnosed for a number of months, right, because you don't really expect that the dog will have osteo. It's much more likely they've been leaping around and they've got a cruciate. So you should be able to distinguish the two, but sometimes that doesn't happen, dogs will just have sort of NSAIDs and go home, and eventually it's diagnosed. So earlier detection would be obviously beneficial. And if you have a large breed dog that has discomfort over, the classical sites where osteosarcoma occurs, a radiograph may be valuable to start to look for potential osteosarcoma. And there's a lot of it about, to sort of, the quotes of it there being about 10,000 dogs a year I think is probably inaccurate. And I think that there's a lot more dogs that actually have osteosarcoma, you know, some that we of course never hear of. How could you possibly think about incidence in all the general practices that are seen, and many of the dogs that just are euthanized because they have that disease? So I don't really know the answer to why there's a difference in terms of pediatric, human, and middle to older age dogs. There may well be sort of tests coming along where you could take a dog that was lame, where you might be suspicious of osteosarcoma, and look for circulating tumor DNA and look for particular genetic markers. There's also this study, the GIRL study, which is the Golden Retriever Lifetime Study, that's been done here. I think it's mostly in the US, where they followed about 3,000 Golden Retrievers who are predisposed to osteosarcoma and other tumors, and have collected sort of DNA and blood and so forth throughout their life. So now it's been very valuable. You can take those dogs, you know that they developed osteosarcoma, and then you can go back to all those samples and see if you can actually identify markers that would predict that they would go on to develop osteosarcoma.
Super. Thank you, Nicola.
Thank you. Of course, I'm sure some of the human clinicians would also confirm that it's often quite a while before the human patients get diagnosed. It's obviously due to the age. Often parents will be told that their children are having growing pains, etc., and it can be quite tricky. So perhaps some of the canine studies can help with some of the early identification as well, considering the incidence is so much larger. I think we overrun slightly, but it's been really interesting. Sorry. So it's been good. Well, thank you very much again for taking the time to do this presentation. We will be posting it online later this evening, and it's been really, really insightful to hear about the great work you're doing, and look forward to hearing more about it. So thank you very much.
Thanks very much. Thanks, guys.
Thank you.
Bye-bye.
Bye. Thanks, Eva.